So up next, we have the open forum, Ask the Experts. We're going to be having the same moderators, Dr. Lambert and Deborah Shelton with ACPMP. And we're going to be welcoming back Dr. Levine with Wake Forest, Dr. Turaga and Dr. Eng with the University of Chicago. I want to do a brief introduction of Dr. Eng. For those of you who don't know him, Dr. Eng is a double board certified surgical oncologist who focuses on the treatment of cancers in the abdomen and in particular cancers that have spread to the peritoneum. He specializes in CRS HIPEC and treats a variety of abdominal cancers and is skilled at minimally invasive approaches. So please submit your questions via Q&A and we'll try to get to as many as possible. Thank you.
Okay, well, great. Thank you. Thank you, panelists. So let's see. So the way that we did this, I think Dr. Lambert and I have split up the pre-submits, the questions we got before registration, and then what's coming through live. Dr. Lambert is doing the yeoman's work of monitoring and culling through what's been coming live. But I can say between the two sets of questions, I think we're up to probably over 75 questions. So let's try to kind of do rapid fire as best we can. I think we're both working to collapse questions. I will say some of the questions that we've received have been addressed now through some of the presentations. We realize that's a lot to go back through the presentations, but again, if you don't get your question answered, we'll try again at the regional. If that doesn't work, please feel free to contact the Research Foundation at info@acpmp.org. We will do our level best to get you answers. So let's just start right off. Let's go back to kind of treatment, the treatment bucket, if you will. Got tons and tons of questions about HIPEC specifically, and trying to collapse a couple of those questions. One, patients have a lot of concerns about potential long-term adverse consequences of HIPEC. Dr. Levine, I believe you touched on one, depression, but we also often hear concerns about, are there possible neurological effects? Are there possible cardiovascular effects? So how do we think about that? How do you all think about that? And then does the answer depend? I'm a lawyer by training, so my answer is often, it depends. Maybe that's your answer, but does your answer about long-term effects of HIPEC depend in any way on the chemical agent used in HIPEC? So is it a different answer for melphalan versus mitomycin C? But let's just start with that to kind of mitigate some of those or assuage some of those concerns or validate, depending on what your thoughts are.
All right, I think there's several points you left on. Are there long-term side effects of HIPEC? And yes, there can be. This can be a life-changing operation. It depends upon what needs to be done. And what's going to determine that is what the volume of disease is, whether it's low grade or high grade, and are there complications which are going to ensue after the operation is done. In terms of, are there different side effects specifically for the perfusate or what the chemotherapy is, the answer is yes. In the randomized trial, we found that the patients who had oxaliplatin had a slightly better quality of life over the course of the first 3 to 6 months. Beyond that, it didn't make any difference as far as I can tell, at least not by using the research tools that we're using. The real long-term side effects are going to come from adverse events. So if there's where you sew the bowel together, if it doesn't heal up properly, if you need a colostomy, if you have a wound infection, you develop a hernia, all of those things can have long-term side effects. Specifically, in terms of neuropathy or neurologic issues, there are very few related to the chemotherapy per se. Much of the neuropathy that you might see with something like oxaliplatin therapy really doesn't apply to the HIPEC because you're giving it as a single dose, single time. So you don't see the long-term side effects in general. Now, if you already have neuropathy from oxaliplatin to begin with and you get another dose, can it make it worse? Absolutely. Is that to make it a permanent thing? Not necessarily. I don't think it's particularly worse than the neuropathy you get from an intravenous dose as far as I can tell. And I think I'm giving a long answer to your short question.
No, it was a long question. It was a cheating 2-3 questions in one. Dr. Zhang or Turaga, do you have anything else to add, or Dr. Lambert? If not, I can move on to another HIPAC question.
Well, Deborah, I was going to say it depends. Like you had said,
That's
but,
fair
you know,
answer.
and just really echoing what Dr. Levine was saying was that it really just is depending on the magnitude of the operation, what's done during the operation. Remember, the cytoreduction is separate from the HIPAC in that each is associated with its own set of complications, dependent on the degree and magnitude of operation and amount of disease that there is. Certainly with different methods of hemoperfusion, cisplatin has a non-trivial rate of kidney injury, although again, I think in our experiences at these high volume centers, these are more self-limiting and often resolve, but that is certainly something that is to take in consideration when you're utilizing different forms of chemoperfusion. So I do think we do have to be mindful of some of these potential toxicities and side effects, but certainly we do find that patients tolerate this because again, it's a one-time thing, much better than systemic therapy that's over the course of months.
And I see Dr. Turaga's hand up, and Dr. Turaga, I want you to of course respond, but also I'm going to cheat and ask one more HIPAC question, and maybe you can lead with that. And then I want to give the wheel to Dr. Lambert because I'm sure she has some live questions. But speaking about HIPAC, how is the agent to be used in HIPAC determined? So we see a lot of mitomycin C, not always. So from your standpoint, like, what is the thinking behind what you choose? And, you know, we heard earlier about with organoids, we can maybe drill down and see what might be more effective, but what is the current state of play? What is the thinking? So.
Thanks, Deborah, for that. In fact, I raised my hand just to say that we should probably get the opinion from Dr. Lambert, because I do think, HIPAC as a long-term event, cytoreduction and HIPAC. I think it's easy for us as physicians to kind of think about sort of that short spectrum of 3-6 months of follow-up and recovery. And I know we all follow patients for a long time, but I think these are, pretty traumatic events overall. And I do think, Ed's group has done a really nice job of sort of looking at quality of life long-term. But I think the concept of survivorship is something that we do need to embrace within our field more. Which I think actually Dr. Lambert is probably uniquely qualified to, because she certainly has a strong interest in that. To your question though, Deborah, about the agent choice, I think Dr. Levine's big randomized trial, the only randomized trial for appendix cancer, did show relative sort of equivalence between mitomycin and oxaliplatin. From the colorectal literature, the short duration, high dose oxaliplatin doesn't work very well. So I do think mitomycin still is one of the good agents for intraperitoneal chemotherapy as it stands today. But I think in terms of the future, it's incredible. I mean, I think that's really what the symposium is about, is how do we highlight, better advances, either using organoids or using other ways of identifying, sensitivities of these tumors to agents, and then also delivering agents maybe in a different way, like HIPAC. Or maybe, could you even put immunotherapy intraperitoneally? Could you do other CAR T cells intraperitoneally? Could you inject STING agonists intraperitoneally? So I think the whole world is open to us right now. And I think really that's where patients, ACPMP and treating teams like ourselves, we all have to get together to build up on this and build new trials. But I'd be very curious to hear Dr. Lambert's opinion on the survivorship part.
Thanks, Dr. Turaga. I have to agree with everything that you guys have said. And I just can't imagine how going through this surgery cannot be a life-altering event, even if it is successful, even if you recover back to better quality of life, like some of Dr. Levine's studies have shown, by 3 to 6 months after the surgery. It's still a major, it's just, there really isn't a surgery that's quite like this, right? You come out with a scar, often from the breastbone to the pubic symphysis, and major organs have been resected, multiple of them, and then you've had heated chemotherapy, put in the abdomen. I think there's not quite anything like it. And I am so impressed and humbled by the people who trust us to provide this for them, and watch them with the grace and strength and dignity that they go through this for the motivation that they have, right, to live longer and spend more time with their families and their loved ones and accomplish things. And there's been some comments in the question that people have been putting in about how they're 20-year survivors, and and they're still coming to a symposium like this to learn more and to support other people. So without a doubt, it's something that nobody would ask to have put on their plate in life. And yet here are people that are coming out to support those who are earlier on their journey with this cancer, and rally around each other as a community, and to provide hope. And that's, you're exactly right. And that's what I love about being a part of this community as a surgical oncologist, and all of you who are my colleagues, and those of us, the rest in the HIPEC community, who are really just sort of dedicated to making this better. It's quite an honor to be a part of this community. So thank you. But there is kind of a little bit of a follow-up question on this topic as well from the live chat. It was in regards to side effects. What do you guys think about the different side effects between just normothermic IP chemotherapy and HIPEC? Are there side effects of the hyperthermia itself?
Ed, do you want to speak about that, or?
I haven't done a great deal of normothermic perfusions, to be totally honest. I tend to doubt there would be, but it's going to depend upon what your temperature is. Here at Wake Forest, we run 40 degrees at the outflow cannula. That's about 105. Once you start getting over 43, 44 degrees, you can have basically irritation of the peritoneum or peritonitis. There's a hyperthermic pancreatitis you can get. I think you have to be careful in terms of what the temperatures are.
Mm-hmm.
But in terms of the side effects likely to be experienced by patients, I'm not sure it's going to make a whole lot of difference up to that temperature range. If you're really, and there are centers which have really pushed the temperature. I don't know that any of them are represented on this call, but I don't know that the patient's going to experience a whole lot if you're perfusing at 37 or 40 degrees.
Yeah. Dr. Turaga or Dr. Eng, in your experience with the iterative HIPECs that are at the normal temperature, or they're HIPECs rather, iterative HIPECs, have you seen anything specific about those side effect wise?
I think patients have generally tolerated it pretty well. We've done, iterative HIPECs with the high-grade appendix patients with mitomycin, and then with the gastric patients with cisplatin and mitomycin. And overall, they do tolerate it pretty well. But I do think some of them do have some chronic pain from perhaps some inflammation along the peritoneum over time. When they get to that sort of third or fourth one, they get a lot more sort of pain along the incisions in the anterior abdomen. But I think overall our patients have tolerated it pretty well. And I think the key to it is also not just us, it's the nursing protocols and the team that we have in the operating room that helps mitigate these issues. When we start cooling the patients, when we're anticipating we're going to induce hyperthermia, I mean, these are all things that are, every sort of piece of the puzzle matters just as much. And I think when you're at an institution that does it a lot, like all 3 of ours, you have these streamlined protocols which make a huge difference.
Just to add to that though, one of the very interesting things for me is when we separated the cytoreduction from the HIPEC, we always have this sort of fear that, oh my God, HIPEC is such a toxic delivery of intraperitoneal chemo. There's hyperthermia, there's chemotherapy, there's perfusion, there's flow. And so how would patients do? And, early on when we started doing this iterative HIPEC, we kept patients in the hospital. We were worried about their bowel function and this and that. And, we got to COVID and we wanted to get patients out of the hospital. Patients were feeling pretty good. And we started discharging everyone day 0. And I would say that, certainly patients have some side effects with, the intraperitoneal chemo part of it, but it's very, very minimal. I would say it's very low compared to even IV chemotherapy. And so I've been very impressed with the tolerability of intraperitoneal HIPEC. And I think that's also very similarly mirrored in sort of the PIPAC trials, where patients are being sent home the same day. So I think the delivery of intraperitoneal chemo seems to be pretty well tolerated overall. And I think the sort of big concern about it, I think, is more. I think it's just when it's additive to a big cytoreductive surgery, that's when I think we worry a little bit more about the morbidity. But I don't know what Ed or Laura, I don't know what you guys think about it.
Ed?
I think you're absolutely right. Just a couple of things I wanted to echo is I think Oliver put forth nursing team and nursing support, having that kind of support and experienced teams, not just the surgeon, but the whole hospital system makes a big difference. And again, the vast majority of the toxicity is going to be from the cytoreduction without question. I mean, it's not the intraperitoneal chemotherapy, it's what the surgery represents. Because some of these operations, you can remove all or parts of 10 different organs in the abdomen. That is an enormous impact on patients, even if things heal up very, very well. Whereas if you do some of just a perfusion as an outpatient, just running the chemo around is actually remarkably well tolerated.
Yeah, I would agree with all of that. Absolutely. I guess we do know from the ovarian data that the the normothermic intraperitoneal chemotherapy that's given as part of the treatment with systemic chemotherapy, the bidirectional, can have its challenges, and some of those regimens can be a little bit difficult. But again, these either the iterative HIPEC or the one-time HIPEC, I agree. It's really the cytoreduction with the HIPEC that I think causes the most side effects, if you will. Mm-hmm.
Okay, great. So if you see my eyes shifting all over, I need new glasses and I'm just looking. So we have 17 minutes. I know that Lauren's doing a great job as taskmaster, keeping us all on track. One additional question kind of from the treatment surgical side, and then maybe Dr. Lambert, we could switch into sort of post-treatment surveillance type questions. Something that I know you all don't want to see, patients, caregivers never want to see, but it's a reality. And that is, we get a lot of questions about aborted surgeries, aborted CRS HIPECs, and what goes into a decision to abort. And then perhaps just as important, if not more importantly, what do those, what is advisable for those patients then that end up to not be eligible for CRS HIPEC? What are some options for them? I think we heard a lot about great research going on, and maybe that's the answer. We've got our standard chemo and there's research, but any thoughts you have on that? One, as surgeons, what goes into a decision to abort? And then two, what is the recommendation for those patients or patients that didn't even get as far as the OR? There's already a decision that they're not going to be eligible at that time for CRS HIPEC. Tough situation.
Yeah, maybe I'll start it off, and I think it'd be nice to hear everyone's thoughts. I think the decision for HIPEC, or actually cytoreduction in HIPEC, it's a complex decision, just like any other medical decision, and it actually starts in the clinic. It starts when you see each other in clinic. It depends on the patient, their goals, what cancer they have, how they feel and look, and then of course how we believe the disease is going to do. I think the skill of the surgeon is important. I know you've heard this a million times over, but in appendix cancer surgery, we do know that if the prior surgical score is high, which means if other surgeons have operated before, it makes it very difficult to go back into surgery. If you look at Dr. Levine had one of the slides, do not open planes. That makes it difficult for us to do cytoreductions again. So it is important that when you select your treating team, you're selecting a team that knows what they're doing. And then finally, the judgment intraoperatively, is dependent on a few factors. Again, it depends on how the patient is doing. If the patient's not doing so well, that could change the nature of the operation. The findings that we find during surgery, which could include a higher burden of cancer than expected. Usually the biggest thing that prevents us from doing a complete cytoreduction is sort of this cancer that engulfs the blood supply of the intestines called the mesentery as it goes up onto the intestinal surfaces. And that's a little difficult to take out. But the judgment, and I can tell you this from my own experience, my own judgment has evolved over the last 2 decades. And so what I thought I could not do before, I can do now. Technically, what I thought I should do, I don't do now. So I do think that experience is it comes from all the mistakes we've made or all the lessons we've learned. And so I do think it's very important. And in fact, whenever we abort a procedure at University of Chicago, it's very common practice for me to call my partner, so Dr. Eng, to say, hey, we're going to stop doing this operation. Is this okay? Like, it's not that I'm not doing this because, some other extraneous factor is interfering. Is this a fair thing to do? Because we realize that, aborting a procedure like this has a very difficult prognosis for patients afterwards. I think the challenge for patients, even though we're talking about all the exciting things today at our symposium, the biggest challenge is that a lot of these diseases are not well measured on imaging. And so it's very difficult to refer these patients for clinical trials. So yes, there could be all these advances in immunotherapy and, KRAS mutations and everything else. But the reality of the matter is we can't see it. And so that's why it is important that, as an organization, we advocate for our patients to be eligible for these clinical trials. We do have to advocate for patients, especially with visual confirmation of disease, that we can get them on clinical trials and have alternative surrogates for response. So I think the bottom line answer, I would say many factors that determine it. Experience of the team really, really matters. And I do think that, the bowel surfaces are usually the limiting factor for surgery.
Great. So I'm looking at time. We have still a few minutes. I do want to get to some imaging questions. Dr. Lambert, you probably have live questions, but does anyone want a quick like 30-second add on to what Dr. Turaga just said, or can we move on?
I'll put in a couple of things. I think in terms of aborting these procedures, I'll tell you that is, and I can tell you for the surgeons who are on this call, that is our least favorite operation. Nobody wants to do that. We do a lot of things to minimize that with quality imaging. You can minimize the risk. Sometimes the preoperative laparoscopy can help somewhat, but even that's not 100% predictive. So you want to avoid that if you can. It's really a non-therapeutic laparotomy. So when you say aborted, it depends on where you're at, and it depends on what tumor grade it is. Now, we're just talking about appendix here. The rules are different if you're talking about HIPEX for gastric cancer, colon cancer, that sort of thing. For a low-grade tumor, I'm going to persist and try to reduce everyone as much as I possibly can, because there really is no meaningful medical therapy for it. There's promising things on the horizon, yes, but there really isn't a whole lot in the way of chemotherapy. So I'll push surgery as far as I can. For higher grade tumors, I'm going to use the same sort of PCI cutoff I use for colon cancers. Because once you get beyond a PCI of 15 or 20 for a really high grade appendiceal cancer, even if you can try to reduce them, the outcomes are really not very good. And the morbidity to be paid for high PCI cytoreductions is high. So again, this is one of those judgments you have to make. Unfortunately, a lot of those judgments are learned at the expense of patients who have suffered because we persisted when we shouldn't have. And I think Dr. Turaga hit the point exactly right on. The difference between an experienced HIPEX surgeon and an inexperienced one. Push the technical aspects and attributes as far as you can when you need them. And when you find something where even if you have a technical feat that you can peel something off of something, it may not be the right, just because you can doesn't mean you should. Mm-hmm. And that's exactly the kind of judgment you need to have your surgeon to have for you.
Oh, yeah. Dr. Lambert, were you going to say something, or?
No, just agreeing.
Great.
Ed is, I think, a few years ahead of Karen and I, and we're a few years ahead of Oliver, and we can all appreciate what everybody else is saying.
Great. So I thought we could switch into some of the post-treatment surveillance, but I also, Dr. Lambert, I don't know if you've got any live questions that you want to bring in, or?
No, I think this would be a good time to transition to that.
Okay, great. So trying to distill the questions that we get about imaging to kind of bucket up into one huge question. And I'm sure, Dr. Lambert, you're doing the same with your lives, but basically, so many questions we get about what is the preferred imaging for post-treatment surveillance. What is the protocol? So what type of imaging, at what sort of intervals are we talking about? Does the answer, again, Dr. Ng, just, it depends? I mean, we see so many patients getting so many different recommendations and don't know, is there a best practice, or how should patients think about it? And last but not least, is there a sort of milestone where patients can now kind of relax a little bit in terms of worrying about a recurrence? So imaging surveillance, what type, at what intervals, and are there certain milestones where maybe a little sigh of relief can be had?
Dr. Ng? Want to take that one? It depends.
Yeah, well, I mean, it does in a way, and you know, it obviously depends on many factors, which include the biology of disease, the burden of disease, and the timeline of everything. And so I think, you know, unfortunately, I am being vague because it depends on all these different aspects of the patient's recovery period and disease process and so forth. You know, I think, as Dr. Harmath had outlined, there are different advantages and disadvantages of CAT scans and MRIs. And there's also the practical aspect of, you know, where can you get an MRI that is of the quality that you expect, and also sort of the distance that patients have to travel to get that. And, you know, CT itself is much more feasible and more readily reproducible and a lot quicker for a patient to undergo. I've had many patients who we want to get an MRI on, and they say, well, you know, I don't want to be in an MRI for this duration of time because I just can't tolerate it. And, you know, is that okay? And you know, of course it's okay. And so, you know, I would say that with this disease process, regardless of what we do, in many instances, I mean, the recurrence rate is high. Now, the time at which it occurs depends on the biology of disease. But that being said, we watch patients closely. You know, we get a post surgery imaging usually anywhere between 6 to 8 weeks, and then depending on whether or not they get chemotherapy afterwards or surveillance, you know, typically imaging is every 3 months for the first year or two, and then we start to space it out after that to maybe every 6 months and every year after that. But at the same time, it really just depends on the disease process and the patient.
I think I would just, and maybe you guys know something that I don't know, but I'm not aware of any study that says MRI detects tumor or recurrence early enough before a CT scan that it will make a difference in the oncologic outcome, right? And so I know, but there are concerns, you know, I think a lot of people, especially young people who are going to be looking at long-term surveillance with CT scans, have concerns about radiation. I know, I think we share some concerns about MRI. I know I do, just because I can't read them as well myself, and I could read CT scans much better. But if you have a very good MRIist and a protocol, somebody that you trust, then it's a very good option, and it can pick up certain things better than CT scan. But do you guys know of any, or do you believe that using MRI over CT or vice versa is going to detect something early enough that it's actually going to impact something oncologically?
For what it's worthwhile, I'm going to tend to agree with you. I still prefer CT scans for several reasons. Number one, they're more widely available. Like you, I'm much better reading at a CT scan than I am for an MR. And what it is true that there's research data that shows that MRs are slightly, and I mean slightly, more sensitive to small volume lesions. But when you're talking about following somebody for recurrence after a HIPEC, you're not looking for subtle changes. And there's been so much surgery with most of these, there's going to be subtle changes in the peritoneum all the time. One of the reasons we never get post-resection HIPECs for months, because there's so much inflammation, residual fluid. I don't know what it is and how to interpret it. So usually most of these patients for low grade, I wouldn't bother following anybody more often than every 6 months. For high grade, you can make an argument for 3 to 6 months, if and only if it's going to change your chemotherapy. And I would keep in mind that in general, if your tumor recurs very quickly, you're going to probably go on chemotherapy for some time anyway. There's data from us and other centers which has shown that if you have to repeat the HIPEC in less than a year, the outcomes tend to be quite poor. So there's not a reason to look for really subtle, maybe ifsy, whatsy lesions. It's going to be very hard to put a laparoscope in there and to go back in there and biopsy it again. The best test is actually remains the test of time, although that's the hardest on the patient's nervous system. There's no question about it.
Yeah.
Good. And then Dr. Hay had done a presentation on this, but we did get some questions ahead, and maybe for those that missed that, we do have patients that prefer to rely on the circulating DNA test for surveillance rather than imaging. Given the current state of play with the circulating DNA tests, it sounds, I mean, my takeaway was that we're just unfortunately not to the state where that has really good, solid predictive value yet, but there's research going on. What do any of you all follow your patients just with the circulating DNA test? I mean, what do you think about that?
I think, I can share some of our experiences. So we've obviously been very interested in following our patients with circulating tumor DNA for two reasons. One, obviously, can we detect recurrences early? But then more importantly, can we actually then sequence those to identify mutational changes? Can we then understand what's happening to this disease over time? And so preliminarily what we've found, which is actually which is actually an interesting observation, is that even patients who have low-grade carcinoma peritonei from the Lamens or the DPAM from the Ronnet classification, even they shed more DNA in their plasma than normal controls, than healthy people. So even though we know that these diseases stay in the peritoneum, they don't spread outside, so we do see that, but that is only detectable at very, very small levels, at nanogram levels. The high-grade patients, they do shed much more circulating tumor DNA. We've been using a colon cancer test called Signatera, which is similar to sort of another test called Garden, which people use. But we've been using that in a serial fashion to track patients, perhaps more from like an interest and academic standpoint than maybe as a clinically relevant standpoint, because like you said, Deborah, we don't know what to do with that information. So I'll give you a classic example of, how this conundrum creates, or how this test creates a conundrum, which is this test basically detects DNA in the blood. And so let's say we have a patient with high-grade cancer and we're getting this along with the CT scans and tumor markers every 3 months or every 6 months. And we've had some patients in whom it turns positive, but we have no other cancer anywhere else. And I think to Ed's point, do we do a laparoscopy? It's already a difficult laparoscopy. Do we give them chemotherapy? Do we just keep waiting? And the answer has been to keep waiting. And in fact, we've had some patients in whom a positive test turned negative and a negative test, turned positive. And so it's a little variable. We've found, at least in our preliminary analysis, we have an abstract coming up to SSO, but basically only about 56% of our patients with detectable cancer have a positive cell-free DNA in commercial tests like Signatera. So I think the jury is out. I don't think any of us could confidently tell you, yes, this is the best test to do. I do think we do it. I do think it creates anxiety for my patients, 100%. I think it creates anxiety for our teams. But we're hoping that we can maybe unlock something for the future and maybe then give patients access to trials. Because I feel like without imageable disease, we're just struggling to put anyone on trials. And I'm hoping this could be one modality to get there.
Okay, I'm looking, thank you for that. Now I have right at 2:45 Eastern. So Dr. Lambert, do you have anything to close us out?
No, I just want to thank the panel and thank Dr. Levine, Dr. Turaga for co-organizing the event with the ACPMP and the Huntsman. And I think I feel like it's been a great symposium. I learned a lot as well. So I appreciate everybody's efforts and hope we have good regional symposium experiences as well. So,
and thank you for everything that you all are doing.
And thank you, Dr. Eng, for joining the panel too.
Great.
Of course.
Thanks, everyone.
Thank you guys so much. for that wonderful session and for taking the time out of your busy schedules to come on and answer some questions. I also want to thank Deborah Shelton with ACPMP for helping moderate with Dr. Lambert. So that kind of concludes our general session for this afternoon. We are now going to take, I think, about 15-minute break before we launch into the 3 regional sessions that are going to be hosted by each of the institutions. So Wake Forest, Huntsman, and the University of Chicago. Those links are in the chat, but you will have also received them to your email. If we didn't get to your questions today, please note that we did get all of them in the Q&A, and we will have a full report. So we'll try and answer those and maybe send some recap emails if possible. The recordings for this general session and for all of the regional sessions will be available at acpmp.org/Symposium 2021. We will also circulate the links to the recordings on our ACPMP Facebook page too. Again, I just want to take the time to say a great big thank you to all of our speakers today that came on, speakers from all 3 institutions, but also from other institutions that made guest appearances. And I look forward to having everyone participate in our regional sessions. Thank you on behalf of the ACPMP Research Foundation, and see you soon.